What is up, my friends? It is Mike, Bodywork teacher in Seattle. I'm getting excited for tonight's Embodied Happy Hour live stream, and the subject for tonight is distinguishing our methods from the mechanisms that underpin them. Fair warning, if you really enjoy endless, pointless Facebook debates about our various theories for what's happening, then this live stream probably isn't for you. But for everyone else who's interested in connecting the theory of our practice to our practice in new and insightful ways, this may save us a lot of frustration. The reason is that many of us in the world of bodywork and physical medicine come into the field with a primary goal of becoming masterful at treatment methods. And in that process, we take on a schema. We take on a way of seeing the body and of theorizing what's going on under our hands. And so as we practice the method, we get better and better at seeing through that lens. And then when hopefully the body changes under our hands, when the person in our care gets better, we are likely to attribute the change to the theory that we had learned as part of our treatment method. This kind of a process, there's nothing wrong with that. However, as we begin to investigate that theory, we need to be willing to evolve the mechanism that underpins the method that we have. So let's take trigger point theory as an example to see what I mean. In the world of myofascial trigger points, there's this amazing and kind of self-contained model developed initially by Dr. Travelle, David Simons, others at USC in the middle 20th century. And it's a very instructive example for a lot of things that we tend to encounter in the world of bodywork and physical medicine: fascial lines, reflex points, etc. In this case, what Dr. Travelle found was that if you squeeze muscles and sift muscle fibers, you will occasionally find a taut band. And if you explore that taut band, you will find perhaps a hyper-irritable nodule, an exquisitely tender spot. And when you squeeze that spot, you will experience, the patient hopefully, will experience pain and other forms of referred sensation, not just where you're squeezing, but in another place. And there wasn't a clear model for why that other place was getting activated. And so a whole theory sprung up as to why. And numerous theories have arisen, some having to do with a malfunctioning sort of reflexive regulation of muscle tone. It has to do with the sort of muscle spindle fiber and what we call the gamma efferent motor system, the sort of way of maintaining basal tone in the muscle. Another set of theories has to do with the motor end plate, so a malfunction as to where the nerve meets the muscle fiber, and sort of a spill of calcium at the motor end plate. And the idea was that these referred sensations had to do with these malfunctioning muscle fibers, and that's when things got really interesting. There was a treatment strategy that arose that had to do with sort of deactivating these trigger points in some order or another, so that, at a simple level, you just find them and you treat them. But in a more sort of elaborate version of the same theory, these points relate to each other in kind of a constellation or familial relationship. And so you can have like primary and secondary trigger points, and it becomes kind of a predictive model. Like if you see this muscle tight or this thing dysfunctioning, then you go through this sort of step of treating this muscle and that muscle. That more elaborate theory depends on a mechanistic theory of trigger points, which may or may not be true. So go back to the phenomenon. That's my first advice to you. Go back to the primary phenomenon that got described. The primary phenomenon was you put your hands on a muscle and you sift through. You find a taut band and a hyper-irritable spot. And when you squeeze it, it's not just tender locally, but it refers sensation, sometimes in a non-obvious spot. In this example, we've got the sternocleidomastoid muscle, and you squeeze multiple spots, and depending on if you're on the superficial head, you'll get a certain distribution of discomfort. This is a sort of statistical plot, but if you squeeze that superficial head, you might get sort of an arc of discomfort around the orbit of the eye, the cheek, a little bit at the dome of the head, and a little patch in the back. Very interesting. If you squeeze the deep head, you'll get more localized islands of discomfort around and behind the ear and on either side of the forehead. What's going on there? Well, we don't know. We don't know. It's a complex system with many parallel explanations. When we have taken the theory of the malfunctioning myofiber, we have done many things to investigate this. Number one, we have inserted a microdialysis needle into the area of a trigger point, let's say into the area of that taut band and hyperirritable nodule. And what do we find when we sample the fluids in that tissue environment? We find the elements of inflammation. We find inflammatory cytokines, elevated levels of substance P, of CGRP. These are messenger chemicals meant to kick up the storm of local inflammation, and they're oftentimes secreted by peripheral free nerve endings. What does that mean? Well, it doesn't make us confident that this theory of a malfunctioning myofiber is necessarily the correct one. Neither do we find in practice that one can find one trigger point and predict the existence of others. In fact, if you take numerous practitioners and you test the reliability between them, they will find different trigger points. So it's not like you have consistency between practitioners, and neither does what we see in the tissue necessarily correspond with a muscle-centric view of the pathology here. So what I'm hoping to do later today is to discuss potential alternate explanations and just widen out the field of potential mechanisms. Because this example, as juicy as it is only one of a whole host of examples of methods we've learned that come with a clinical lens and cause us to collapse our theory down to just one potential mechanism. The body has many potential ways of producing the changes we see. And so we need to have a little space between the methods we practice and the phenomena we encounter at the macro scale and the underlying mechanism, which could be many, in which we need to sort of loosen our grip on as we evolve our practice. For example, with trigger points, we could entirely decenter muscle fibers and come up with a very plausible mechanism, which is to say the inflammatory cytokines, the hyperirritable spot, and the taut band could be an artifact of an irritated peripheral nerve. Could be a place where a nerve is perforating muscle tissue, it's irritated there, it's sensitized, it produces referred sensation. You might say, well, the referred sensation doesn't always correspond with the path of a given nerve. True, it does not always correspond with the path of a given nerve. But to explain this, you'd have to make an exhaustive account of how pain referral happens in the body, and we do not have that account in neuroscience yet. What I can tell you is that, for example, with the neck, the innervation that crosses the SCM is either cranial nerves or upper cervical nerves, and these are shared by brainstem nuclei. So it well could be that an irritable spot here gets misinterpreted by the central nervous system as an area of crisis elsewhere in the head. And so I suppose the idea is be playful, be spacious, capacious with your underlying explanation, and believe in your method. If it works, right? At least evaluate your method by a separate ground from the mechanism that underpins it. And I hope this helps folks talk past each other a little less. Tonight's live stream, we're going to go deeper into this example of myofascial trigger points and also apply the same kind of lens to other methods in the world of bodywork. Fascial lines, reflex points, energetic explanations of change. Again, making lots of space for the phenomenon as it reaches our senses, while getting curious about potential alternate mechanisms underlying. See you tonight at 6:30 p.m. Pacific on Neurofascial Approach on Facebook, or hopefully, if I can figure it out, on YouTube. And hope you can join me. Be well.